Okay, so welcome to those joining us remotely. And we're going to make sure we are focused upon the screen. It looks pretty good. Go ahead and get your eyes in. So certainly a histiocytic infiltrate. Yeah, many 2-ton giant cells. So xanthogranuloma, very good. So xanthogranuloma, or if the child is juvenile xanthogranuloma. So it's a JXG unless the patient's not J, in which case it's just an XG. Characterized in its early life by sheets of histiocytes. Then around the periphery of the lesion, the top, the sides, the bottom, you start to get wreath giant cells, and then they lipidize. That's the life of the lesion. Early, just sheets of histiocytes. Later, wreath giant cells starting around the periphery, then they lipidize and become 2-ton. And what do you call the cells when they're really large?
2-ton.
2-ton. Very good. Good. Could be on an exam.
Looks like it's here on crust.
So there's a crust, and in that crust you have lots of staph bacteria, staph colonies, which we'll point out in a second. So a little bit of PEH. So here are all the staph colonies. Let's get them where everyone can see. There, staph colonies, and then crust, PEH, and then the lesion itself. Inflammatory or tumor?
Well, leaning toward inflammatory.
Do you see inflammatory cells, or do you see an epithelial mass?
Epithelial mass.
Epithelial mass composed of pale cells hanging off the epidermis, peripheral palisade, thick basement membrane zone.
Cylindromal.
So thick basement membrane zone, similar to what you'd see in a cylindroma, that fits together like jigsaw puzzle and has no cytoplasm to the cells. Hangs off the epidermis, looks like the outer root sheath of the follicle. So trichulomoma. So trichulomoma, they can be tricky. These trichulomomas hang down from the epidermis as opposed to a clear cell acanthoma that is the epidermis. Right? Clear cell acanthoma is a segment of the epidermis. Trichulomoma hangs down from an epidermis composed of pale glycogenated cells, peripheral palisade, thick basement membrane zone. When multiple associated with? Cowden syndrome, correct.
Looks like we've got infiltrate in the dermis.
Yep, infiltrate in the dermis. Kind of a
Interstitial.
busy dermis, kind of interstitial. At the periphery,
Oh, dermatofibroma.
some collagen balls. So it certainly suggests dermatofibroma. Let's look a little higher. Do the cells look like the cells of a dermatofibroma?
Not really.
Do you see them flattening off next to one another like little box cars?
Oh. Is it breast cancer?
This is metastatic breast, mimicking dermatofibroma at scan. So metastatic breast carcinoma, carcinoma en Curras, which can be fibrotic, so mimicking a fibrous neoplasm at scan, looks like a busy dermis, traps a little collagen at the periphery. One clue is, where's the acanthosis? No acanthosis, right? So that's one clue. And then nodular lymphoid aggregates, a little unusual, might even make you think of desmoplastic melanoma, but would certainly make you want to go a little higher and look at the cell morphology. In this case, nuclear molding of cells adjacent to one another, characteristic for breast carcinoma.
So it looks like fluid-filled areas.
Fluid-filled areas, so it's a sweaty tumor, very sweaty, right? And what are these little clear round things?
Ducts.
So they're ducts. Does it palisade or no palisade?
It looks like it palisades.
Let's go higher.
Oh no, it doesn't palisade.
No palisade. So this is something that distinctly has no palisade, has visible cytoplasm, has ducts, and has this curious osteoid-like stroma.
Yeah, like a peroma.
That's poroma stroma, the osteoid-like stroma, which is a million wraps of basement membrane zone around a vessel, creating that osteoid-like stroma. So poroma, acrospiroma, hydradenoma, they're all the same, right? So poroma, acrospiroma, hydradenoma, all the same family of tumors. What they have in common is they're made of cells that differentiate towards the acrosyringium. They have visible pink cytoplasm, whereas the ones that differentiate towards the secretory portion have just nucleus, no cytoplasm. They have ducts. They never palisade. They often have cystic degeneration. And they have the characteristic poroma stroma. Sheets of uniform cells. And then, what's it just starting to form around the periphery? Some wreath giant cells, so it's sheets of small cells that if you stain them, stain as histiocytes. And then around the periphery, you're just starting to get a few wreath-like giant cells. So this is an early, a young, a very JXG, in that this is a young xanthogranuloma. Early on, it's just sheets of histiocytes that can be variously epithelioid to even a little spindled looking, which this one looks. And then around the periphery, it starts to form those giant cells.
So we have irregular acanthosis with hyperkeratosis.
Acanthosis, hyperkeratosis. And what's with these pink areas where at the level of the granulosum, everything kind of turns red and the nuclei turn pycnotic and black?
Things of Veronica.
No, that's fingernail work, right? That's excoriation. So anytime you have these superficial red or pink areas where it should be blue, granulosum, that's excoriation. That's fingernail work. So if you want to know what death will look like, it's red, right? Death is red, at least in H&E. You also said there's acanthosis, there's hyperkeratosis, there's angiofibroplasia of the papillary dermis, vertical streaking of the collagen. So this is LSC, or if it's localized bump, prurigo. You know, same thing. Prurigo is a bump, LSC is a plaque, but they're essentially the same pathophysiology. So papillary dermal angiofibroplasia, meaning proliferation of vessels and collagen, often with time, vertical streaking of the papillary dermal collagen. This one has sort of a this week sign in that your older corneum was normal and then what's below it is the altered corneum. Tells you it's maybe not been going on months, but just a few weeks. And then you have the zonal pink necrosis of the granulosum, which tells you the fingernails have been at work.
Dermis and subcutis.
So the dermis and subcu.
I see some ringed giant cells.
Wreath like giant cells, so it's a JXG, right?
No.
No, but it shares some features with XG. How about the collagen here?
It's very dense and kind of necrotic looking.
Yeah, kind of dead.
So
And there's
NXG.
debris on it, and there are cholesterol clefts. So we don't have a big enough piece, because this is a narrow punch, not an excision. We can't see the X-shaped zones of necrosis. But you see there's necrosis, or so-called necrobiosis of collagen, but then there are wreath cells like a xanthogranuloma, which is how it gets its name, necrobiotic xanthogranuloma, NXG. NXG typically has neutrophil debris, so it's dirty on the necrotic collagenous areas. Cholesterol clefts, typical. If you have a bigger piece to look at, the necrobiotic areas tend to intersect and make X's, advertising that it's an NXG. But in a narrow punch, you may not be able to appreciate that. Okay, that's what you get. Right? We just read them. We don't always control what we get in the lab.
So, I think there's probably a little papule.
Little papule, or at least they gave you a little piece.
There's some sort of dermal infiltrate.
Yeah, and is it diffuse, interstitial, or perivascular?
Looks perivascular.
So kind of perivascular.
Is it histiocytic? Can't tell.
So their lymphs,
Lymphocytic.
it's a little bit mixed. Their lymphs, there's a few polys in the vessel.
And
There are
eos.
these binucleate red cells.
Some eos.
Yeah. So it's a polymorphous infiltrate with some eos, some neutrophils within the vessel. Differential.
Just like arthropod or drug.
Yeah. Dermal hypersensitivity response. So urticarial type reaction, arthropod drug. Don't forget dermatophyte causing that. So that's a very good differential. So it looks similar to Grover's disease in that you have clefting, villi formation, acantholytic disc keratosis with corons present and crusting. So if there are multiple small lesions, Grover's disease, if this is a solitary lesion that was ruled out squamous cell carcinoma, then probably warty disc keratoma. And if the patient has V nicking and red and white stripes in their nails, Berries. So it's an acantholytic disc keratotic disorder, which includes the spectrum from Berries disease to warty disc keratoma.
Area of necrosis with clefting.
So area of necrosis, or at least pallor and some edema, where the collagen becomes hypocellular. So then the question is it really amorphous, or can you still see ropey fibers?
Some ropey fibers there.
So you still see ropey fibers, which is very different from the necrosis or necrobiosis that you would get in NLG or NXG. Here, it's still intact collagen fibers. It's become hypocellular, but the collagen itself is not necrotic. Surrounded by more hypercellular areas, you have these at the periphery. A little collagen trapping at the periphery, more hypercellular and then hypocellular areas. And if you compare the epidermis there, which is really quite thin off at the edges, to what's directly overlying it, is it equally thin overlying?
Not really.
A little bit thicker, right? A little acanthotic overlying. So what do you think? Dermatofibroma. And characteristic of DF, as you follow them over time, is they develop those hypocellular areas, whereas a DFSP is uniformly cellular across the field. So DFSP is a classic translocation sarcoma. Translocation sarcomas don't have much atypia. They just have far too many nuclei, and they're uniformly cellular across the entire field. So you have pleomorphic sarcomas that have, this may shock you, pleomorphism of nuclei, but are not uniformly hypercellular. You have translocation sarcomas that are uniformly hypercellular across the field, and then you have benign fibrous tumors that often have hypo and hypercellular zones. It's a good way to start out. When you get into the soft tissue world, there are some characteristic lesions like low-grade Evans tumor, low-grade fibromyxoid sarcomas that have hypocellular areas as characteristic. But to start out with dermal tumors, the characteristic dermal tumor that has hypocellular areas like that is dermatofibroma.
So looks like we have an increase in sebaceous glands.
Increase in sebaceous glands.
Maybe just sebaceous hyperplasia versus...
Yeah, it could just be sebaceous hyperplasia. Could be, if it's a guy with a greasy scalp, could be normal androgen effect. How about the hairs? Big strapping hairs or kind of small hairs?
Very small.
And if this were a scalp, what do you think about the hair diameter for a scalp?
They're small, so
Pretty small, so miniaturization. So name 3 scalp conditions that give you miniaturization of hairs?
Androgenic.
Androgenic would be number 1. And you can say androgenetic if you want, but you're saying extra syllables, so. Androgenic alopecia or pattern, I got you beat by several syllables there, right? So pattern alopecia, androgenic, androgenetic, all the same. What else gives you miniaturization? And would give you some lymphocytes left in the fibrous tract and a little pigment left in the fibrous tract and maybe some eos in the fibrous tract.
Trichotillomania?
Trichotillomania has multiple catagen hairs, hair casts, but doesn't tend to give you pigment or inflammatory cells in the fibrous tract. Whereas a histologic look-alike for trichotillomania,
Alopecia areata?
AA. So AA is characterized by miniaturization. What looks just like AA? Syphilis. So syphilis, AA, pattern are your big 3 for miniaturization. And then there's some stable things like triangular alopecia, which is sometimes congenital. That has miniaturization, but it's stable throughout life. So miniaturization, your big 3, pattern, alopecia areata, syphilis, which can look just like AA, additional features of alopecia areata and syphilis, lymphs around the bulb that as the bulb retreats upward become lymphs in the fibrous tract, pigment in the fibrous tract left over from the attack at the hair bulb, and sometimes eosinophils in the fibrous tract.
Looks verrucous in areas.
Looks verrucous, definitely looks verrucous. Coarse hypergranulosis, serum, round perikeratosis, and vertical tears. So it's a wart, right?
I was trying to see if I see atypia in there.
There's definite atypia there. So this is,
Squame.
yeah, or since it's all in situ,
Oh,
full
Bowen's.
thickness Bowen's, and probably, since you said it looks like a wart, papilloma virus induced Bowen's. Lesion on the abdomen. Sebaceous gland associated with a follicle. And then a funny duct filled with something that's kind of apocrine looking. What would give you a bump on the abdomen with a central sebaceous gland and then a kind of funny apocrine-like duct right down the center of the abdomen? So supernumerary nipples, accessory nipples. Remember, the breast is just a fancy apocrine gland.
Can it be early stage of neosebaceous?
So early neosebaceous, interesting thought, except you don't have, well, in early neosebaceous you wouldn't have the sebaceous gland unless it's immediately after birth, and to have a solitary unit would be unusual. It's usually multiple lined up.
see regular acanthosis, keratosis, some carotid keratinocytes,
Forming
crust.
red scale crust, there are neutrophils in there. If you had to say, what letter does that resemble?
V.
A V. 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 It's shouting its name at you. What is it? All those red V's filled with neutrophils. Anyone?
The verrucoxanthoma.
Verruciform xanthoma. So verruciform xanthoma, sometimes referred to as wart on fire, right? Because it's a little papillomatous and has all those red V's. So wart on fire, verruciform xanthoma, it shouts its name at you with all these red V's on the surface. You can also consider them arrows pointing, saying, hey, 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 look down here in the papillary dermis. Because unless you look at high power, you're going to miss those few xanthoma cells down in the papillary dermis. All right? So all those red V's are trying to help you out. They're pointing you down. Hey, look down here. How many times do I have to point down at the papillary dermis, right? 1, 2, 3, 4, 5 red V's, all pointing down to the papillary dermis and shouting the name. I begin with a V, verruciform xanthoma. Just like an XG makes red X's because God is really trying to help you.
How do you say the high power?
Oh, the high power?
Forming cell.
Sure. I mean, the answer is you don't need to because you already have the diagnosis. But then if you go to higher power, yes, there are some xanthoma cells in the papillary dermis. But unless you make the diagnosis at scan, you're not going to make the diagnosis. So it is a scan diagnosis. Red V's, wart on fire.
So we're looking at a scalp again.
Looking at a scalp, and tell me about the size of the hair follicles.
Miniaturized.
Miniaturized, name 3 things that do that.
Pattern, alopecia areata, exposed.
And so now you're kind of working your way through those. So any other things you want to look at?
So I don't see much of an inflammatory infiltrate.
But where would that be? We're at isthmus, so we're too high to see it, right?
Right.
Because you'd expect it down around the bulb. And here we're at the isthmus level. So in transverse sections, it's not uncommon to miss the diagnosis of alopecia areata. Diagnosis is made better statistically in vertical sections because you're at the wrong level to look, unless you have serial sections that carry you down, or unless the hair is so miniaturized that you can see it. So now we're going to look at the vertical section. Do you have any fibrous tracts to look at?
No.
Or not so much in this particular section?
Not so much.
Not so much. So the things you want to see, you're not seeing in this section. Means you need deepers, and this indeed turned out to be alopecia areata. But the bits that you need to look at, the deep fibrous tracts, you're not seeing. Either in your transverse or your vertical tells you you need deeper sections.
Spindly proliferation in the dermis.
Spindle cell proliferation in the dermis.
Collagen trapping.
Collagen trapping. What are these things?
That's a pigment.
And what kind of pigment?
Looks like hemosiderin.
So flip your condenser down. Focus on high power. Focus up and down. If they twinkle at you and they're refractile, and it's hemosiderin, which these do, whereas melanin would not be refractile. Also, the hemosiderin distinctly has just a tiny little bit of a green tint to it, because it comes by way of biliverdin, whereas melanin doesn't have that slightly greenish tint. Right. So what would give you ringed pseudophages?
DF.
Yep. That's essentially pathognomonic of DM, of dermatofibroma. So wreath-like lipidized pseudophage, like a Teuton giant cell with hemosiderin, is essentially pathognomonic of dermatofibroma. Lots of squamous eddies in something that is endophytic and looks a little like outer root sheath, a little like a trichomoma, but with lots of squamous eddies. IFK, inverted follicular keratosis. So IFK, and some things that look similar to that are indeed trichomoma, and some are warts. But where it's clearly an endophytic lesion that looks like an expansion of a follicle or outer root sheath with lots of squamous eddies, that's typical for inverted follicular keratosis.
The crust with some acantholytic dyskeratosis.
So you have a crust and acantholytic dyskeratosis, clefting. So what's your differential for acantholytic dyskeratosis?
Deger's disease, warty dyskeratoma, Haley.
So Derrier's, warty D, Haley. Now, does Haley ever make blue rings around the nuclei?
No.
Or clear rings? No, only red for Haley. So here you see blue rings, can't be Haley. Haley only knows how to make red rings around the nuclei. So, but you said, I think you said Derrier's, you said Grover's, if solitary lesion, warty D, warty dyskeratoma.
So, basaloid neoplasm, it looks like a palisades.
Basically, neoplasm, palisades. What color are the strands?
Pink strands.
What color are the buds?
Blue.
So pink strands, blue buds, horn cysts, radiates outward. So anastomosing pink strands, blue buds is pincus.
Right.
Radiating outward, pink strands, blue buds with horn cysts, infundibulocystic BCC.
Okay.
And then basaloid follicular hamartoma can look identical.
Okay.
So BFH, basaloid follicular hamartoma, is a clinical distinction. I have little bumps all over my body or in a Blaschkoid segment, and they've never changed since I was 16 years old. That's not a basal cell, right? That's BFH. But it looks just like infundibulocystic BCC. Pink strands, blue buds, radiates outward from central infundibular-like areas.
Okay, so we're on acral skin.
Acral skin. Tell me about the papillodermis.
It looks, it's like white, so it looks kind of edematous.
Edematous. And then tell me about the lymphs around the vessels. Do they overlap, or does every one have a little white space around it?
A little white space around.
So that's so-called fluffy edema, where every lymphocyte sits by itself with a little white space around it. So what's acral with papillodermal edema and fluffy edema around vessels? Every lymphocyte has its own identity around the vessel.
PMLE with the dermal edema.
So papillodermal edema with neutrophils, sweets, with lymphs, PMLE, acral with lymphs, and fluffy edema around vessel, perniosis.
Okay.
So perniosis and PMLE look exactly the same, except that one's on acral skin and has the characteristic fluffy edema, which you don't get in PMLE.
Okay.
So here, every lymphocyte has a little bit of white around it. They all sit by themselves. Whereas in most infiltrates, they kind of overlap and cluster, right? Very characteristic of PMLE, of perniosis, acral skin, papillodermal edema, every lymphocyte surrounded by a little bit of white. That's characteristic for perniosis. And then what do you have to look for in a patient with perniosis?
Lupus.
Lupus. Significant percentage of lupus patients have perniosis. So that's lupus pernio, right? No, lupus pernio is sarcoidosis. So kind of misnomer. But Chilblain's lupus is not the same as lupus pernio, which is sarcoidosis. Unfortunate names. So lymphoid infiltrate, interface, lots of red cell extravasation. And when you look at the interface change, do you have lots of holes out of lymphs, or is it kind of a lymph in every hole? Maybe hard to tell in this one, but perhaps closer to a lymph in every hole. Interface with red cell extravasation, lymph in every hole, pityriasis lichenoides. So spongiotic with red cell extravasation, PR, or Ducus and Capitonochus type of pigmenting purpura. Interface with red cell extravasation, pityriasis lichenoides, or Gougerot bloom type of pigmenting purpura. In this case, if you can see really a lymph in every hole, that leads you more towards pityriasis lichenoides, so-called Mucha-Habermann disease.
We have a cystic-like cavity,
So
osteoid-like material, and surrounded by monotonous blue cells.
So
Poroma.
So cystic cavity cells. So you thought poroma, given the cystic cavity. Now, poromas form ducts. Does this form ducts or does this form keratin cysts?
Keratin cysts.
This one's doing keratin cysts. Poromas never, ever, ever palisade. Does this have a palisade?
Yes, it does.
It does. So not poroma. So blue cells, peripheral palisade, fibroblast-rich stroma surrounding puts it in the pilar group. Sweat gland group don't palisade. Pilar tumors palisade. Okay. So it's a cystic pilar tumor with horn cysts, and if you look at different areas, it can look like germinal epithelium. It can have shadow cells like polymatrical change. It even has some reddish trichohyalin granules. So it's differentiating towards all parts of the hair follicles. So what would you call a cystic pan folliculoma?
Panfollicular.
Yeah, cystic panfollicular.
Without hair shift, also can be linear.
So sometimes you can have actual hair shaft formation too. Yeah.
Okay, so looks like we probably have a small papule.
Small papule.
Thinking like angiofibroma.
Yeah. Angiofibroma concentric around vessels and around the follicle. So angiofibroma, when solitary, what do you call them?
Fibrous papule.
Fibrous papule. When multiple, they can be associated with
Tuberous sclerosis.
tuberous sclerosis or
MEN1.
MEN1 are the two big ones. Burthog-Dubé is another one that can have.
So, looks like nests of cells in dermis.
And what kind of cells?
Could be melanocytes.
Do they have nuclear pseudoinclusions like melanocytes?
Histiocytes.
So more likely histiocytes, especially because you're seeing syncytial cells. You have cell to cell to cell with no nuclear membrane in between. The cytoplasm is syncytial. That's good for a histiocyte. And then do they have a nice lymphoid clothing on, or are they naked?
Naked.
They are naked, so you have naked granulomas, or since I was taught dermpath by Southerners, naked granulomas. So naked granulomas, what's your differential?
So sarcoid.
So sarcoid, what else?
Infectious.
Infectious, although infectious tend to have lymphocytes.
Okay.
So a so-called tuberculoid will tend to have lymphocytes, but leprosy sometimes can be as naked as sarcoidosis. They tend to be more horizontally oriented following neurovascular bundle. So sarcoidosis, cutaneous Crohn's,
Okay.
beryllium and zirconium granulomas, all can be naked granulomas in skin. And that was sarcoidosis.
Okay.
Polarize them, find silica. What does that mean?
Silicosis. Or like working.
Still sarcoid.
Oh, okay.
So have you ever skinned your knee?
Yes.
You have silica in your skin.
Okay.
Do you have granulomas around your silica?
No.
Who gets granulomas around their silica?
Sarcoid.
You got it. So it used to be thought years ago that silica granulomas were a look-alike for sarcoid. Now we say it just is scar sarcoid. Everyone's got little nidus like that of silica. The sarcoid people form granulomas around that nidus.
Superficial and deep.
Superficial and deep perivascular infiltrate. What kind of cells?
EOS.
EOs. Is there much of a lumen to the vessel, or is there endothelial swelling? Yeah, swollen endothelium. So superficial and deep, polymorphous with EOs, endothelial swelling, bug bite.
Yeah.
We have to show you that because you never see those in Charleston.
Never.
Never. Never gets hot here either. Okay, let's get that. Get this. So,
So there's acanthosis.
so there's acanthosis,
hyperkeratosis.
hyperkeratosis.
Alternating.
Are the suprapapillary plates thin, like psoriasis, or are they normal?
They're normal.
They're normal. So hyperkeratosis, sort of a psoriasiform hyperplasia, but the suprapapillary plates are not thinned. Where do you have more hyperkeratosis?
Oh, the hair follicles.
Hair follicles. So they, clinically, these would be follicular spines, right?
But also, I think I'm seeing alternating
And
cornea
they're,
between ortho and hyperkeratosis.
and it's kind of patchy,
Yes.
right? Almost in a checkerboard pattern, one might say.
Yes. PRP.
PRP. Very good. That's the PRP that is not platelet-rich plasma. That's the PRP that is pityriasis rubra pilaris. Let's do. I don't think that one's fair. We're gonna skip that. You don't quite see enough of it to make it fair.
What was it?
Radius in tissue, but you didn't have enough of it there to see.
Okay, so looks like a dermal infiltrate.
And your collagen is normal, or your collagen is not normal?
It looks hypercellular.
Yeah, so the collagen's a little bit dense and ropey, right? And then what kind of cells? Nuclear pseudo-inclusions suggest what? Melanocytes. And then your melanocytes are your nuclei. You certainly have a little bit of pleomorphism. They're larger. They're nuclear pseudo-inclusions, so melanoma is a thought. You know, it certainly has ropey collagen. I see one little bit of lymphocytic inflammation, but not a lot of lymphoid aggregates. Do you see anything at the junction?
No.
Not really.
Right.
And the cells are kind of spindled and epithelioid. So what other kind of nevus can give you ropey collagen and spindle and epithelioid
Blue nevus.
melanocytes? So blue nevus can. Those often have a wedge or bulbous shape. The other thing would be a desmoplastic spitz nevus. But you're in the right ballpark thinking of desmoplastic variants of melanocytic.
So this is benign.
That one was benign. Correct. You can have significant pleomorphism in Spitz nevi.
So we have a hair shaft.
You have a hair shaft, correct?
And looks like there's pigment in the middle.
Pigment, or that's actually airspace
Oh,
when it looks black like that. And is it continuous or discontinuous?
discontinuous.
And so what is that abnormality?
Is trichoraxis nodosa?
No, that's a breakage of the hair shaft. This is just a discontinuous airspace that's polyannulati.
Okay.
Gives you sparkly hair, spangled hair, sparkly hair. Every time I've seen it, it's the entire family is there bringing little Timmy in. What's wrong with little Timmy? Why is his hair so dull and lifeless? Little Timmy is the only normal one in the family. Everyone else has the polyannulati. It's the one hair shaft abnormality people like because their hair is sparkly, right? So you have to tell them little Timmy is normal. Okay, keep going. Yep, clear cells. Lots of blood vessels around the. And you are correct, this is metastatic renal carcinoma.
So we have a really thick epidermis, erosions, across formation, a lot of dead reds. V-shaped error.
So what is this?
Rosiform xanthoma.
Verruciform xanthoma, wart on fire, multiple red V's with neutrophils in the epidermis. And if you don't see that at scan, you're never going to make the diagnosis looking higher. Fortunately, it's lost a little bit of its hematoxylin. I think we're going to have to skip that one just because it's not. Well, we can try it. So, what kind of cells?
So we're in the dermis here, right?
In the dermis, eccentric nucleus, ample cytoplasm.
Is that a reniform nucleus?
It is.
So this is LCH?
LCH. Well done. Done with no hematoxin. That's like with one eye tied behind your back, right? And yet you did that beautifully.
There's a lot of pigments. Okay.
It's, actually, that was some air under the
Okay.
cover slip.
There's a dense infiltrate.
Dense infiltrate of what kind of cells?
Histiocytes.
Histiocytes, and what's happening here?
We have a giant cell, wreath giant cell around the periphery.
And what's around the periphery of the wreath? Why is it a little bit clear there?
Lipid.
So this is
like a later JXG or XG.
xanthogranuloma. Yep. Very good. Yeah, the dermis, there's not enough space between the collagen bundles, right? The white space is gone, and there's a little bit of cellularity, so it looks like a busy dermis. So what do you want to do with a busy dermis? Look a little closer at the cells. There certainly are some bigger ones in there. So at this point I'd probably want to stain it and see what those cells are. And they're all epithelial. And this is metastatic breast again. Subtle, but it's not a normal dermis, right? It's a sclerotic busy dermis. So your question then is, what are those cells? Could this be desmoplastic melanoma? And breast is one of those things that does a subtle busy dermis with sclerosis, and this turned out to be breast carcinoma. And with that, I think we are done.